Hello and salute or Prost. Today we're going to be talking about alcohols. These are some of the oldest known sedatives. They're widely ingested by man and animal alike. But instead of cocktail time, we'll be primarily focusing on the deleterious effects of alcohols because these are more likely what you'll see in the emergency room. What types of clinical situations do you usually see that are related to alcohols? Well, ethanol itself is widely available, and often you'll see its toxic effects simply because animals drink it as readily as humans. So left unattended, your beer might be enjoyed by your dog, your goat, or even your sow. Even wild animals eat fermented fruit to the point of intoxication. Methanol is another simple alcohol that causes sedation, but also blindness. And finally, ethylene glycol is an alcohol that, apart from being sedative, is also nephrotoxic. In this lecture, we'll also point out the possible use of more complex alcohols that you can safely exploit for their sedative activity. Trichloroethanol, a metabolite of chloral hydrate, is one such example. Now, alcohols are simple organic compounds characterized by a saturated carbon atom attached to a hydroxyl group. There are three potential sites where the hydrogen atoms surrounding the carbon can be substituted with a more complicated group, represented here by the letter R. Compounds with only one of the three possible substitutions are called primary alcohols, as exemplified by ethanol, methanol, or even propylene glycol. Although the word alcohol refers to any of these structures, it's commonly reserved for ethanol, the substance in alcoholic beverages. Now, if you replace the hydrogen ions on the alcohol with more substitutions, you can make either secondary or tertiary alcohols. As the number of substitutions increases and the complexity of the molecule increases, the sedative activity of these molecules tends to increase as well. As a result, tertiary alcohols like trichloroethanol are more potent sedatives than ethanol, for example. The most common alcohols that you might deal with in veterinary medicine are methanol and ethylene glycol. Although the content of these compounds in common household items has decreased over the years, they're still found in a variety of items that seem to be attractive to the non-discriminating taste of animals. Now, methanol, for example, is found in wood alcohol, denatured alcohol, gas line antifreeze of older model cars, paint thinner and remover, picnic stove fluid, soldering torches, windshield wiper fluid, and when I researched this extensively, even Egyptian embalming fluid. So keep those pets away from poorly prepared home brew and the Egyptology wing of your local museum. Now, in contrast to methanol, that has no distinct taste, ethylene glycol is sweet, making it even more attractive and more dangerous to children and pets. Ethylene glycol is found in hydraulic brake fluid, radiator antifreeze, solvents for paints, and even in the solution you put in your cabin's toilet up north during the winter. Alcohols are fairly lipid soluble, so they're absorbed rapidly across lipid bilayers and end up in the circulation soon after they've been ingested. Because of their high lipid solubility, they're also distributed widely to all organs of the body, including the brain, where it produces sedation, disorientation, ataxia, and so forth. Metabolism is primarily responsible for the termination of alcohol's actions in the body. Metabolism happens in the liver by the enzymes alcohol dehydrogenase, followed by aldehyde dehydrogenase. Because these enzymes are easily saturated by even low concentrations of alcohols, metabolism is by zero-order kinetics at a rate of about 1 ounce per hour. Now, in terms of beverages, for easier comparison, 1.5 ounce of hard liquor, that would be an 80 proof mix, is equivalent to about 6 ounces of wine or 12 ounces of a 5% beer. When ethanol is metabolized by alcohol dehydrogenase, it's converted to acetaldehyde. This compound is relatively safe, but in high concentrations, it causes intense nausea. And the accumulation of acetaldehyde is in fact responsible for the hangover effect that ethanol produces. Once metabolized by aldehyde dehydrogenase, it's converted to acetic acid, which is also innocuous in low concentrations, but high concentrations can cause acidosis. The metabolites of alcohols are all excreted readily into the urine. However, alcohols themselves are reabsorbed back into the kidney and into the circulation at a much higher extent than their metabolites. So in the absence of metabolism, it takes a much, much longer time to rid the body of alcohol. Now, alcohols are a great way to illustrate zero-order kinetics compared to first-order kinetics. Now, first-order kinetics is probably the most common rate of degradation of drugs. It involves the metabolism of a certain percent of the drug per unit time. In contrast, zero-order kinetics indicates that the drug is metabolized at a certain amount per unit time rather than percent. An example of this would be you can give 2 people 1 ounce of liquor per hour for the rest of their lives. But you can keep one of those people drunk and the other sober by the difference of only 1 pint of liquor. The dynamics of this is shown on this graph, where the y-axis indicates the blood level of alcohol in the 2 individuals. The dotted line shows the cutoff of sobriety, and the x-axis shows the time elapsed with the short arrows indicating ingestion of 1 ounce of liquor every hour. But in this example, the large arrow shows that the very first drink differs. Person A, red, drinks only 1 ounce per hour at this point, whereas person B, in blue, drinks a pint of liquor at first, and thereafter only 1 ounce per hour. As you can see, the plasma concentration of person A goes up and down, but metabolism keeps up with an ingestion so that the level that would reflect inebriation is never reached. However, person B achieved a higher plasma concentration initially and could never quite recover from that, in that the metabolism never eliminated more than the hourly ingestion of liquor. So their plasma concentration remains well above that producing inebriation, while person A remains sober no matter how many additional shots are drunk. This example emphasizes the importance of a loading dose for drugs that are metabolized by zero-order kinetics. Even if you take the drug religiously for years, if you need that loading dose, your blood concentration will never be sufficient to, for example, either kill bacteria in the case of antibiotics or control seizures in the case of an anticonvulsant. Because ethanol, methanol, and ethylene glycol are metabolized by the same enzymes, we can show them on the same slide. Ethanol is converted to acetaldehyde by alcohol dehydrogenase, and then to acetic acid by aldehyde dehydrogenase. Methanol is converted to formaldehyde and then to formic acid by the same enzymes. And ethylene glycol is converted to glyoxyl and glyoxylic acid. However, it's further modified by oxidative decarboxylation to a combination of oxalic acid plus formic acid. Now, in the case of methanol, the synthesis and accumulation of formaldehyde is what's responsible for the production of blindness. The retina is exquisitely sensitive, and formaldehyde essentially pickles that retinal tissue. But if you treat the animal with antizole, 4-methylpyrazole, this enzyme, the very first enzyme, is blocked, and the methanol will eventually be eliminated by excretion in the urine. It'll take longer time to rid the body of methanol, but it will prevent the production of formaldehyde. In the case of ethylene glycol, the toxic metabolite is oxalic acid. It tends to be a very strong chelator of calcium, and calcium oxalate, the combination, is very insoluble. So it precipitates in the urine and mechanically damages the tubules of the kidney. But if you treat the animal with either antizole, that's shown here, or antabuse, disulfiram, this prevents the generation of oxalic acid. The effects of ethanol are much less toxic than either methanol or ethylene glycol. Ethanol produces a safe sedation, but with lots of ataxia, and that's the drunken-like gait. It can only produce hypnosis and anesthesia at doses that also produce a dangerous degree of respiratory depression. So high doses of alcohol, or even smaller doses that are ingested rapidly, can be fatal. In spite of the old cowboy films where people chug a few swallows of whiskey to kill the pain before an arrow is pulled out of their body, there's actually no analgesic activity of ethanol. It would do as much good for the person removing the arrow to have a drink as it does for the patient. Even at non-lethal doses, the metabolism of alcohol produces dysphoria because of the accumulation of abnormally high concentrations of acetaldehyde. In fact, antabuse, disulfiram, was originally designed and is still used in aversive therapy to make people sick when they drink ethanol by blocking aldehyde dehydrogenase and causing the acetaldehyde to accumulate. In other drugs, this may also be the effect, and that's why you can't allow animals to drink ethanol when they're taking some other drugs like antibiotics, for example. The accumulation of acetic acid can be sufficient to produce acidosis after ingesting large volumes of ethanol. This slide is just to illustrate that the retina is a bundle of nerves that are located in an unprotected fashion outside the central nervous system. So it's more susceptible to methanol toxicity than any other tissue in the body. This slide is to reinforce the concept that ethylene glycol is nephrotoxic because of the accumulation of oxalic acid chelating calcium in the kidney tubules. So how do you treat toxicity from these alcohols? Ethanol suppresses respiration, so that should be monitored and maintained when necessary. Ethanol also inhibits the release of ADH, and because of this, diuresis develops, so fluid therapy might be needed to prevent dehydration. In the case of methanol, antizole, as we mentioned, should be administered. And in the case of ethylene glycol, disulfiram, antabuse, is indicated. However, in either methanol or ethylene glycol toxicities, if you don't have antizole or antabuse, you can infuse ethanol at a high dose for a long time. That would have to be days, or until you get those drugs, to saturate the alcohol dehydrogenase enzyme, competing with the toxin and preventing its metabolism. In each case, sodium bicarbonate should be used to treat the acidosis that's caused by the production of acetic acid or formic acid. Remember that either antizole or antabuse can be used to treat ethylene glycol toxicity. Either one will inhibit the formation of oxalic acid, but only antizole can treat methanol toxicity and prevent the formation of formaldehyde. If you give antabuse to an animal with methanol toxicity, it will actually worsen the condition because it increases rather than decreases the accumulation of formaldehyde, just as it increases the accumulation of acetaldehyde after ingestion of ethanol. Ethanol is used for a variety of purposes. As I mentioned, in an emergency, it can be used to treat methanol and ethylene glycol toxicity, but it has to be administered by infusion of a high dose for a long time. Ethanol as a treatment is not ideal, but certainly superior to the consequences if no treatment is given. If you want to produce a permanent local anesthetic effect, injection of ethanol to a nerve can cause necrosis and usually a permanent sensory loss. Another use is if a sow has rejected its offspring and there's a lactation failure, essentially, as in agalactica. A beer or two sometimes is sufficiently sedative that it soothes over the situation. Apparently, pigs like beer. But remember that large doses of ethanol will produce respiratory depression, usually the cause of death in most overdoses. It also causes hypothermia, dehydration, and acidosis. And so for these reasons, it's not the first choice for treating methanol or ethylene glycol toxicities, which do require high doses to saturate the liver enzymes. The last alcohol that I want to cover is one that's generated by the metabolism of a non-alcoholic drug, that is chloral hydrate. Chloral hydrate is an old sedative with a slow onset of action and a long duration of action. It can be used in cattle, pigs, and horses. In old films, it's referred to as a Mickey Finn when it's mixed with alcohol and produces a sleeping medication, that is to induce hypnosis. Chloral hydrate itself is not sedative or active in any usable way, but it's metabolized to trichloroethanol, a tertiary alcohol. And it's the trichloroethanol that produces its sedative effects. It has no skeletal muscle relaxant properties, so it's good when used together with local anesthetics for standing surgeries. It can also be used when a sedative is needed for long periods of time and you don't want to have to re-administer the drug frequently. But there are definitely disadvantages that explain its less frequent use clinically. It's caustic and bitter to the taste. It has such intense gastric irritation. It causes emesis in dogs and necrosis when given subcutaneously. So it's usually given via a stomach tube, either orally or high in the rectum. Once in, it has a high degree of protein binding, so it can displace other drugs that are simultaneously administered. The slow onset of action and long duration of action is because the chloral hydrate takes time to be converted to trichloroethanol and then to be eliminated. Because it's a chlorinated carbon molecule, like all halogenated drugs, it has the potential to cause cardiac arrhythmias. And if you're doing something painful, you need to use an additional drug to provide any degree of analgesia. The constellation of effects produced by alcohols like chloral hydrate and ethanol can be compared to other sedative drugs like acetylpromazine, xylazine, diazepam, methylcarbamol, and guaifenesin. Only xylazine, diazepam, and methylcarbamol and glycerol guaiacolate have muscle relaxant properties. But only diazepam and methylcarbamol are used widely for their anticonvulsant activities. And only xylazine and perhaps glycerol guaiacolate are antinociceptive, that is, analgesic. So in spite of the fact that you have lots of drugs with sedative effects, they won't all be appropriate for the same situations. Unfortunately, to use these drugs wisely, their characteristics need to be learned by rote memorization. To do this, they'll be consolidated and recalled more easily if you test yourself using this kind of a chart, comparing and contrasting drugs. Then practice using the drugs even in fictional case studies.